You're watching CTOM TV. Knowledge is power. If you had kind of your wish list that everybody out there who's just received a diagnosis of cancer, understandably, like you're frantic, maybe trying to hope for the best, or maybe just feeling hopeless, or all of the above, what are the things that you wish those people knew, like, right away?
Wish they knew or wish they would do?
Well, let's start with what you want. What do you wish those people would do right away?
Proper imaging.
Proper imaging.
Yes, definitely proper imaging.
Okay.
And proper diagnostics is really everything.
Okay.
So, I think an inherited genetic panel, a tumor DNA sequencing panel, perhaps a liquid biopsy sequencing panel, in a perfect world, get all three of them. Monitoring with exosome-based liquid biopsies, I think, is the way to go. It has a very specific niche in the monitoring aspect of it, but I think it's very complementary with PET-CT. I would like to see more PET MRIs. I don't know what's happening with that technology now. I know Germany and India have been using it, and when we've compared PET-CTs to PET MRIs in patients that have gotten them, they really seem to be on par with each other. Almost, perfect mimics of each other. So we've seen.
Say that again.
So we've seen cases where patients have had a government PET-CT, and then they've gone off to India or Germany or one of these places to get a PET MRI. And then they've come back with a PET MRI, and the PET MRIs typically show the exact same results as the PET-CTs.
So why get one then?
Because you don't have the radiation dosage of a CT.
Oh, I see. So it's the MRI versus CT on the end of the PET there.
Yes, that makes a difference.
Thank you.
Yes.
See, so you got to explain this stuff to us. So a PET CT has radiation. A PET MRI doesn't.
Has minimal radiation.
Minimal radiation, and you're saying that the results are equivalent.
Yes.
So
from what I've seen,
right.
Small amount of patients, but
I see. So that's why you're saying it would be great to see it, because then people can have fewer amounts of radiation and equal results.
Yes.
Okay, so let's go back to what you started with, what you wish people would do when they're first diagnosed with cancer. And the first thing you said is proper imaging.
Yes.
So if we're going to talk about, let's talk Canada, then US here. So in Canada, what kind of imaging is used typically for diagnosis, and why wouldn't you call it proper?
Well, you're using a CT scan at best.
Okay.
MRI too.
Okay.
Both of those are great for detecting shapes and shadows.
Okay.
But they do not look at biological activity, even with diffusion. And that's a problem.
Okay.
You need to have biological activity.
So shapes and shadows just tell you something's there.
Yes.
What does the biological activity tell you?
It tells you that population of cells is actively metabolic.
Okay.
And if it's highly metabolic, then there's a good chance it has a high chance of metastasis or growth.
Ooh.
So it allows you to target individual tumors. And, many cases, a tumor will get targeted with radiation therapy or something, and it won't be the most aggressive tumor in the body. They'll target it just based on size.
Because based on a CT scan or an MRI,
yes, exactly.
Which is just showing the, as you say, shapes and shadows.
Shapes and shadows, yes.
Okay. Whereas the PET CT shows
biological activity,
which means how aggressive it is.
And how fast it's growing.
How fast it's growing.
Its percentage of necrosis.
How much the cells are dying, and therefore how well the treatment's working.
Exactly, yes.
Where again, you can't see with CT, it's just, in fact, we've had cases where people have had their treatment ceased because on the CT scan it looked like the tumor was getting bigger, right?
Yes.
And then it turned out the treatment was working fabulously, and it only looked bigger because there was so much cell death.
Exactly.
Yes. Yeah. And
so that's typically with immune therapy. We've also had cases of the opposite where patients have been on treatment for quite some time, and when we got them a PET CT, we found that they never had cancer in the first place.
Yes, we have had that.
A few cases. Yeah. So
yes.
But in most cases, what happens is the patient is staged incorrectly, and when we get them a PET CT, we see that they're actually at a higher stage than they were originally diagnosed at.
So So proper imaging first. Make sure, A, that you do have cancer, and a PET CT is the best way to do that.
Exactly.
Or if you can get one, apparently a PET MRI, which is equally as accurate but less radiation. So that way you can find out, yes, for sure you do have cancer, where it is, which tumors are most aggressive. And then again, that can inform things like surgery and radiation. And even if there's a biopsy sample to be taken for you for further testing, then the surgeon can make sure that they take the biggest or most aggressive tumor.
Exactly.
Yeah, so lots of good reason to get proper imaging. So if your cancer diagnosis has been based on a CT scan or an MRI, you might not even have cancer, and there's a lot of information that you don't have. So yes, definitely. You also said then genetic testing. So some genetic testing can be done without a tumor biopsy, and some can't. So tell us a little bit about, again, in your fantasy plan for people that have just been diagnosed. They're getting they're getting a PET CT now, and then what else are they doing with this genetic testing?
So there's a few points I'd like to really focus on with genetic testing. You know, a lot of times when we go look at a patient for genetic testing, the doctors typically say, well, we want to use the latest tumor because that's going to show the latest you know, changes. The problem is that what you want to do with genetic testing is you want to focus on an older sample. And the reason you want to focus on an older sample is you want to have a good idea of what has caused the cancer in the first place. In other words, the key molecular features that started out the cancer.
Got it.
Because they're going to be in the highest percentage of cells in the body. So there's going to be early mutations, and there's going to be late mutations, and of course there's going to be emerging mutations. We really like to focus on the early mutations because they are going to be capitulated in all of the metastatic deposits.
Okay, say that in English.
They're going to be there throughout the vast majority of the tumor cells.
Oh, okay, got it.
In the body.
So they're guaranteed to be present everywhere.
Not guaranteed,
but not guaranteed. Nothing in medicine is guaranteed. I'm learning.
Nothing is 100% either.
Right. Okay, so most likely to be there versus these emerging mutations that you might find in some
No, not necessarily.
All right.
So you want to focus your tumor DNA sequencing on a sample that is going to be the best example and representative of all of the metastatic potential.
Okay.
And that is by picking the early mutations.
Okay.
And typically the earlier mutations are going to be better targeted.
Meaning?
There's going to be more targeted drugs for them, more data on them, more information on them.
Because they're more common?
Yeah, they've been around longer.
Okay. All right. Well, they happen early in the evolution of the tumor, and so they have the most amount of research on them. I see. Okay, but again, because more people might have those mutations.
Right.
Got it. Okay.
And so a lot of the changes we see when we look at later biopsies, you know, the theory is that you want to look at the latest biopsy. But, you know, if you look at the latest biopsy, it's a small snapshot of what all of the tumors in the body are doing. And it's going to be very inaccurate because you're just not going to be seeing what's going on in the rest of the, you know, the rest of the cancer.
Okay, so that right there is really important for people to understand. That if your doctor is saying, let's look at the
latest biopsy. Yeah.
It might make sense on a certain level, but not really, when you understand the whole concept.
And a lot of the changes you do see in the later biopsies are going to be treatment related.
Okay.
So damage caused by chemo drugs and so on.
Right. So those are important, but not as important as those early mutations.
So the thing is then you have your general mutations, you have your original mutations. So of course emerging mutations and later mutations are important, but the nature of these later mutations and these emerging mutations, typically they're going to be at a very small minor allele frequency. In other words, they're going to be at a very small percentage. So your chance of finding these dangerous emerging mutations that may have a targetable drug for them is going to be much harder with a biopsy because you're just randomly poking into pieces of tumor and hoping that it has that. So, and the problem is when you look at these mutations, one of the big mutations that we see a lot of is copy number variation. So we'll see a reduction in tumor sequencing or tumor suppressors, and we'll see a increase in proto and oncogenes. So increased copy number of them, which means typically higher expression.
Right.
So
that's not good.
No, and also when a gene copies itself, it typically copies itself through a process of retrotransposition, and that can create a lot of damage. So you get a copied, you get a series of the gene copies, but they're not copied perfectly, so they're probably mutated and non-functional or super functional, or just in a bad way.
Yeah.
Yes. So the problem, copy number variation, we see this all the time. One example is HER2. When we see copy number increases in HER2, it changes between the cells. So some cells will have higher copies than others, and it changes between the tumors. So when you look at the tumor as a whole, this tumor may be HER2 hot, and then another tumor next to it may be HER2 cold. Or some of the cells in that may have super high copy numbers, and then other cells will have lower copy numbers. So you have to look at the type of mutations that you're targeting and understand how these mutations function in the role of cancer progression. So for these sort of mutations, what you want to do, you want to be looking at liquid biopsies. And things like Garden 360 is an excellent panel. There's a bunch of companies doing different panels now. Foundation One has their liquid panel. They're kind of limited. They're not able to look at a lot of the genome. They look at specific regions, and they typically only look at about 90 different genes, 90 to 95 different genes.
I think it's 70 actually.
Is it? Okay.
I think so.
Okay. Maybe those are some of the fusion proteins they include then. So that's
it's not very broad.
It's not very broad, but
No.
that's the technology you want to use. And you can do that by looking for key mutations. So one of the things that we understand with lung cancers, after they've been on lung cancer patients, after they've been on EGFR inhibitors, is they have a tendency to develop an EGFR T790M mutation. That's what we call an emerging mutation. And that will prevent the standard therapy, which is the EGFR inhibitors, the first generation EGFR inhibitors, from working.
Oh, wow.
There's also a second mechanism that can cause progression in these patients, and that is called a c-Met copy number variation. So we'll see increased c-Met. So the best way to test for those two is with a liquid biopsy, because it gives you a representation of the entire body and all of the tumors together. Right. Not just, this tumor versus that tumor.
So if you're going to do fixed tissue sampling, you want to get one of the earliest
ones.
And then if beyond that,
you're looking for emerging treatments, you look at liquid biopsies.
Okay. Right, which is a blood test. As far as you at home are concerned, you just have a couple of vials of blood drawn, and then all of the magic happens in the lab. Typically those tests take about 2 weeks to get results back and find out what's going on. So even people who are quite late stage can really benefit from those types of tests, because they give you targeted information and make sure your treatment's going to be more effective. Okay, was there, if we're still in the doctor's office, we've just got our diagnosis, and you're wanting people to do this PET CT or PET MRI if possible. You're wanting them to do the tissue test and some inherited mutations testing. Did we talk about that?
Yeah.
Okay, that would be the liquid biopsy, and then kind of monitoring those emerging mutations that way. And that's it? Are they good then?
Well, that's the general approach.
Ticked?
That's the general approach, yeah.
Okay, so if you've done
and
that...
of course, surgery. I mean...
yes.
You want surgery. You want to remove the tumor tissue as much as possible.
Yeah. Understandably, people want to avoid that if they can, but getting active cancer out of your body as quickly as possible is the wisest choice.
It is, definitely.
Yeah.
The extent of resection is really a driving prognostic factor.
Getting all the tumor out means you're going to live longer.
Yes. I think there was a study, and this is, a very general-based study that showed that in most cases where you have a solid tumor, the stem cells that actually cause that tumor are somewhere in a ball 5 centimeters um, from
Away.
the core of that tumor. So in other words, if you have a tumor that's this big, to actually get rid of the stem cells that cause that tumor, if it's a primary tumor, that is, you take a ball this big out, which is
bigger than 5 centimeters.
No, 5 centimeters from each center,
Right,
so
okay,
10
10
centimeters
centimeters.
diameter. So
Wow.
that's literally impossible to do.
Hence, we use radiation.
Yes, exactly, but that doesn't get rid of it.
Yeah.
So, and we see this with cancers, bone cancers that occur in limbs, for example. For example, if somebody has a bone tumor in an arm or a leg or something like that, typically what they do is they'll cut the leg or the arm right off. And in most of those cases, that gets rid of the cancer.
Because it was within that.
It was in that area, yeah.
Right.
So that's removing the stem cell niche with the tumor.
So it's I'm sure a very, very traumatic approach, but highly successful.
It is,
if they've got that stem cell.
Well, that's where we first started seeing, the evidence that shows that the stem cell niche is not within the tumor. It's nearby, but not within the actual tumor. So just removing the tumor is not enough.
Well, okay, so we've got the imaging, we've got the genetic testing, and we've got the potentially surgery, and then we're monitoring.
Yes.
So we're using that information to find out which treatments are going to work for people.
Of course, yes.
And then we're keeping tabs on that, which we'll come back to in a bit. Okay, so that's their dream plan, or wish. If everybody out there could know that those things are so important, then a lot fewer people would die of cancer, probably.
I think so. I think we'd see much longer survival rates. People do get treated that way. I see people getting treated very well. And then I also see a lot of people getting treated really poorly.
We're missing out again some of that key diagnostic
opportunities, and really you want to focus your efforts on the diagnosis. You really do. That's
and
where you want to put the
money.
money.
Hear a lot these days, which based on the information I've learned from you and my own reading, is a little confusing. But a lot of times patients will call us and they'll say, "Well, my oncologist said I should start with standard chemotherapy and then move to a targeted therapy, as a next step." Which really is some of the opposite of what you're saying there.
Well, I think oncologists are conservative by nature. They're treating a lot of patients. They don't have a lot of time to look into the details of each patient. And they want to do, they're legally obliged to do what they know is best. And they have to go with the information they have and the information that's approved. And in those circumstances, they're doing the best with the tools they have.
Valid.
And, obviously, you hear horror stories, but, I think most cases, the oncologists obviously try to do the best they can and really try to do what they can with what they've got.
Thank you for watching Ctome TV. Subscribe below and stay informed.